Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Vaping, an Emergency Threat to Pediatric Lung Health. I'm Kitty Norris, Assistant Chief Nursing Officer at the Alabama Department of Public Health. Today's program is produced and provided by the Alabama Department of Public Health, Health Media and Communication Division. The expected learning objectives of the program are that the learner will gain an understanding of the prevalence of smoking and vaping, types of exposure, commercial and non-commercial vaping devices, and the composition of e-liquids. The learner will appreciate factors influencing the appeal of vaping to youth and laws to restrict youth vaping. The learner will recognize the risk of tobacco product use in the pediatric population. The learner will obtain competency in the skills required to take a substance use and exposure history during a clinical encounter and to obtain competency in counseling patients on prevention and cessation of smoking and vaping, and an appreciation of the resources available for patients and families. There is no commercial support or sponsorship for the program. There will be no endorsement of products displayed in conjunction with the activity. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and address are on your screen now, and they will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access these materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. No partial credit will be awarded. While content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on April 17, 2026. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. Distance learning conference participants who are not employees, contract employees, or retirees of ADPH will pay a fee to receive continuing education certificates for this program. And now I would like to welcome and introduce our presenters as we get started. Dr. Kyle Blyton is a fellow at the Division of Pediatric Pulmonary and Sleep Medicine at the University of Alabama at Birmingham. And Dr. Robin Gers is a tobacco treatment specialist at the Division of Pediatric Pulmonary and Sleep Medicine at the University of Alabama at Birmingham. Welcome to both. I know you have a lot of great information to cover, so let's go ahead and get started.
Thank you. Good afternoon, everyone. I'd like to thank you for the opportunity to discuss a topic that is near and dear to me as a pediatric lung doctor. And again, the title of today's talk is Vaping, an Emerging Threat to Pediatric Lung Health. A quick overview of what we'll be discussing today. First, we'll review the various vaping modalities available, as well as the composition of e-liquids. We'll discuss the epidemiology of youth vaping, as well as factors that influence the appeal of vaping to youth. We'll discuss some federal as well as Alabama state laws on vaping, as well as some of the pathologic effects and symptomatology associated with vaping. We'll then provide an overview of e-Valley, which stands for e-cigarette and vaping-associated lung injuries. And I'll conclude my portion of the talk by talking about some vaping cessation medications. So what is vaping? Well, it's pretty simple. Vaping is the inhalation of aerosolized liquid. In 2006, vaping products were introduced to the U.S. market, and we saw a sharp rise in their popularity in the late 2010s. There's 4 basic components of most e-liquid devices, including e-liquid storage containers, a heating coil, a battery, and a mouthpiece. Here are some examples of common vaping modalities. We start with the first generation devices, which were these e-cigarettes. You can see that they resemble a traditional cigarette, and they are also disposable like a traditional cigarette. The next generation of devices were the vaping pens. These were reusable devices, and they had all the similar components that we discussed earlier. You can see there are replacement chambers for the e-liquid. The third generation devices were the vaping mods. As the name would suggest here, these devices were modifiable, meaning that the user could change the amount of heating coils as well as the amount of liquid that would be vaped at any given time. Next, the fourth generation devices were the Juul devices, and I think most of us are probably pretty familiar with these. These were reusable devices as well, and you can see that the Juul device is small, very concealable, and it almost resembles a USB drive. The first marketed synthetic nicotine device was the Puff Bar, and currently the #1 device on the market is the Elf Bar. Now it actually doesn't go by that name anymore due to copyright infringement. However, the common vernacular is Elf Bar still. Dabbing is very similar to vaping. Dabbing is a method to inhale highly concentrated forms of marijuana. With the dab, the THC is extracted from a plant using butane or other volatile solvents, and it is placed in the form of either a wax, shatter, or crumble, which you see examples there. Now, those are placed in the upper portion of that chamber, heated. Aerosolized water is heated with it, and it's inhaled through the port. Dabs can concentrate THC to upwards of over 80%, and to put that into context, high-grade marijuana only has a THC composition of about 20%. So these became very highly popularized amongst the youth, given their ability to inhale high quantity and very potent THC in a quick manner. So what is the composition of these e-liquids? Well, it's not just water and nicotine as some would believe. It's 90% carrier solvents, such as propylene glycol or glycerol, about 6% nicotine in the average device, and then the remainder are chemicals involved with flavoring, processed additives, contaminants, and water. There was a study where they performed mass spectrometry on 825 commercial e-liquids, and that discovered over 1,500 different unique compounds in the e-liquids. About 50% of these compounds were only recognized in one e-liquid product, so that should tell you the variability of these e-liquids. And then 43% of the chemicals were assigned in flavoring. Some of these included diacetyl, which is linked to airway damage in animal models, and pulegone, which is found in mint flavoring and has carcinogenic effects or cancer-causing effects in mice. The good thing is that the e-liquid compositions are starting to come down in the number of chemicals. The graph at the top there, graph A, demonstrates a reduction in the total amount of chemicals over the years in the e-liquids, and graph B shows a reduction in the number of chemicals involved in flavoring. Overall, e-liquids contain an average of 20 to 30 chemicals, which is far less than traditional cigarettes, which contain approximately 7,000 chemicals. However, many of these chemicals are dangerous, and many again are carcinogenic. Things like formaldehyde, heavy metals such as nickel, lead, and chromium, as well as many other unsavory chemicals. What is the nicotine content of the average pod? Well, a nicotine content for a pack of cigarettes or 20 cigarettes is about 20 milligrams of nicotine. For one Juul package, it has over double the amount of nicotine at about 41 milligrams. A Puff Bar has the equivalent, again, synthetic nicotine of about 2.5 packs of cigarette. And with the newer pods, these have upwards of 90 milligrams or 4.5 packs of cigarettes per pod. And we must remember that on average, patients are going through one pod per day. So they may not know that they're smoking the equivalent of 4.5 packs of cigarettes. Every year, there's a collaboration between the CDC and the FDA for the National Youth Tobacco Survey. This is a survey administered to middle school and high school students where they fill it out themselves here, and it registers the amount of vaping and smoking. In the past 30 days, over this past year, 10% of high school students and 4.6% of middle school students had endorsed vaping, and this encompasses over 2 million children. Vaping was by far the most common tobacco product consumed, with 7.7% of students endorsing vaping And then the second highest was cigarette smoking at only 1.6%. 35% of students who vaped did so on greater than 20 of the previous 30 days when asked, and Elf Bar was by far the most commonly used vaping device at 57% of the market. 90% of e-cigarette users use flavored e-liquids, such as fruits, candy, mint, and menthol. And many perceived little to no danger from vaping. Here's a graphical form of the rates of vaping over the past 15 or so years. You can see once again that vaping peaked in 2019 and has trailed off a little since then, but most recently stabilizing. The table at the bottom here demonstrates the last 4 years, and it shows that once again, high school vaping rates, at least by self-administered surveys, do seem to be falling. However, over the past 3 years, middle school vaping rates have increased from 2.8% up to 4.6%. And again, we must remember that the students themselves are answering these questions, and they may feel pressure to answer them in a certain way. So there is a high likelihood that most of these percentiles are an underestimate. So what populations are more susceptible to vaping? Well, there's a study of 521 young adult males demonstrating that about 18% were current vapers and 54% had ever tried vaping. The demographics of the vapers, they were more likely to be in a lower socioeconomic status. They did not pursue secondary education past high school, and they were also more likely to be current smokers. From a psychological characteristic standpoint, they had higher rates of anxiety and lower senses of conscientiousness. The National Youth Tobacco Survey also took some data to find that the LGBTQ community was higher rates of vaping compared to heterosexuals. The transgender population had about a 19% vaping rate as opposed to 8.2% in the general population. And 14.2% of those who classify themselves as severe psychological distress vaped compared to 5.5% without. Now, the reason for vaping, actually the number one reason posted by these students, was to self-medicate for feelings of anxiety, stress, and depression. That's even higher than those who just were doing so for the high or nicotine buzz that they received. So what's the conclusion here? It's that our most vulnerable populations who are under much stress from society are more likely to be vaping, and those are the ones that we need to protect. So why do teens vape? Well, there are a litany of different reasons. One, maybe they have somebody in their household, like an adult family member, who vapes or smokes. Number two, the variety of flavors available. Ease of accessibility of these devices. Risk perceptions, again, being potentially lower for vaping compared to traditional cigarette smoking. We already hinted at people who were more anxious or depressed are more likely to vape as well. Just curiosity, since all of their friends are doing it, peer pressure. And then advertisement directed towards youths, unfortunately. So let's talk about the ease of access. Well, in the Birmingham area, I counted no less than 91 different vape and smoke shops, including 30 in the downtown Birmingham area alone, and one that is even about a quarter mile away from our children's hospital. Advertisements clearly directed at youth. So here we can see some of the older Juul advertisements, things like jumping in the air, or fixing your hair, or doing the rock and roll signs with your hands. All things that are clearly targeted towards younger children. Even Santa doesn't always vape, but when he does, he chooses Vape Shark. I mean, this is not targeted towards an adult audience. Luckily, in response to this, the states have started setting up. So, the first state to go after Juul for their youth-targeted advertisement was North Carolina, where Josh Stein opened up a prosecution against Juul, resulting in a $40 million settlement. Over the past few years, there's been a $1.2 billion settlement against Juul. In 2022, Juul was taken off of the market by the FDA. Unfortunately, they might be getting back into the market with that rule pending currently. There are many flavors that are associated and directed towards youth as well. Things like bubblegum, cotton candy, marshmallow, different cereal flavors. They are not targeting adults with these flavors. It's very obvious what they're doing. Luckily, we do have some laws in place to help our youth. There are many federal laws which we'll review first here. The first being the Family Smoking Prevention and Tobacco Control Act. This provides the FDA regulatory content over what's on the outside of the tobacco and vaping products, including warning labels on packaging, advertisement limitations, and trying to prevent minors from buying these products. Tobacco 21 was passed in December 2019. This law raised the legal limit age to purchase tobacco products to 21 years old, and this includes e-cigarettes. The vaping flavor ban was placed in January 2020. This banned flavors targeted towards children, such as mint, certain fruit flavors, candy, and other sweets. The problem is you still see these products on the market today. The issue is the poor enforcement of these laws, as well as large delays in the application for reviewing these brands, and this results in them selling the brand while still under review of the application for these flavors. As far as federal taxation goes, the Build Back Better bill was including a tax on vaping products at $1.15 in addition to the sales tax for these products. Now, the baseline cost for these products are $3 to $7, so this would have been a substantial tax on these items. However, we know that for other reasons, this bill did not pass. What are some of the Alabama vaping laws? Well, there are a few. First, though, vaping devices are not considered tobacco products in Alabama. This means that no smoking signs are not considered to apply to e-cigarettes, no state laws regarding vaping use in public areas, and then there's no taxation outside of sales tax on e-products right now. However, our restrictions do meet those of the federal law. You must be 21 years old or older in order to buy vaping products in the state of Alabama. Medical providers and daycare workers cannot use vaping products while at work. And also, if you have a patient or a child who is 14 years or younger in your car, you are prohibited from vaping in that motor vehicle. There are many municipality laws throughout Alabama. To give you an example of a few in the Birmingham area, it's banned in workplaces, bars, and restaurants in the Homewood, Fultondale, Mountain Brook, and Vestavia areas. And it's also banned in workplaces and restaurants in Bessemer. Some of the pathological effects of vaping on the airway, and there are many. First, I'd like to talk about the cytological effects. There's decreased cell metabolism, proliferation, and viability in those who vape, with the greatest effects being in those who vape cinnamon, menthol, vanilla, and fruit flavors. Much more oxidative stress and inflammation in the airways of those who vape, with increased reactive oxygen species, as well as pro-inflammatory cytokines such as interleukin-6 and interleukin-8. Impact of immune function and susceptibility to infections in those who vape. Infected mice were exposed to e-liquid vapor, had increased viral loads of rhinovirus when infected, and e-cigarette users were more than 5 times more likely to get a diagnosis of COVID-19. Reduced macrophage antimicrobial activity, increased methicillin-resistant staph, or MRSA rather, and then higher mortality in the setting of infections, and human studies found aberrant neutrophil activity function, as well as inflammatory responses when they were infected with influenza. There are many genetic alterations in people who vape also, including impaired damage repair mechanisms and dose-dependent increases in DNA damage in the oral pharynx, or the back of the throat, as well as down into the airway. And then areas of DNA damage includes those involved in the ciliary assembly and movement. This will inhibit their ability to clear mucus and other secretions from their airway. So what do we know about vaping and chronic disease? The long-term effects of vaping are still largely unknown, but there have been 2 meta-analyses I'd like to share here with you. The first looked at 15 studies exploring the risk of asthma symptoms in those who were vaping. Here they controlled for demographics, combustible tobacco use, as well as obesity, and they found more asthma symptoms in those who vaped, more missed days of school secondary to these asthma symptoms. They were more likely to have asthma exacerbations in the past year. This included even secondhand smoke exposure. And this was a dose-effective response, meaning that the higher the dose of the exposure, the more likely they would have these symptoms, with a pooled-to-odd ratio of 1.4 times more likely. Another meta-analysis looked at 9 studies exploring the association between e-cigarette use and COPD. Now here they controlled for those same variants. They found that patients who vaped were more likely to have a diagnosis of COPD, with the highest numbers of diagnoses being those who both vaped as well as used traditional tobacco cigarettes. And then they also were found to have more COPD exacerbations at about a 1.5 higher odds ratio compared to those who didn't vape. Vaping in patients with asthma. Patients with asthma actually have a higher prevalence of vaping than their age-matched peers, with the majority believing that vaping was a safer alternative to traditional cigarettes in the setting of their chronic lung disease. We explored ourselves at Children's of Alabama what the vape exposure was like in our cystic fibrosis patients. These were patients between the ages of 1 year old all the way up to 22 years old. Here we found that 31% of our patients had at least secondhand vape exposure, with about 7% primary vaping. When we narrowed this down to high school age students between the ages of 14 and 18 years old, we found that half of the students had vape exposure, with 20% reporting or endorsing primary vaping. Now, that is even higher than that noted on, about twice that noted on the National Youth Tobacco Survey that we discussed earlier. Vaping exposure in this patient population was also found to be associated with a 4.5 higher odds ratio of hospitalization when we controlled for many covariants. There are many different types of vape exposure. The first being primary use. This, of course, is what we know as where the user inhales the smoke or the aerosol from the device themselves. Secondhand exposure occurs when the aerosol or smoke accumulates in the environment around the user and is held by those nearby. And even third-hand exposure. This is where that smoke and aerosol might cling on to things like furniture, toys, or carpet and be stirred into the air or ingested by people in the household. Secondhand vape exposure has been found to have some consequences as well. So in a retrospective observational study involving over 2,000 high school students who endorsed secondhand vape exposure, they found increased symptoms of bronchitis with daily cough for 3 months, as well as persistent phlegm production with a 1.4 higher odds ratio. And they were also more likely to endorse shortness of breath symptoms with a 1.5 higher odds ratio. E-cigarette and vaping-associated lung injury, or EVALI. This diagnosis first came onto the scene in 2019 after about 6 patients in Wisconsin started showing symptoms. These symptoms can be acute, meaning less than 3 months in presentation, or subacute, 3 to 6 months. And there's a wide array of clinical manifestations with high rates of morbidity and mortality. All of the vaping modalities that we discussed previously have been linked to these cases. So, looking at some of the trends for these cases, the CDC actually stopped trending these cases in February of 2020, so a little while ago. But at that time, there was already over 2,800 cases reported with 68 deaths. The median age of these patients was pretty young overall, at just 24 years old, with 16% of these cases being in those less than 18 years old. I'd like to go back to that 68 deaths out of 2,800 cases. That's a very high mortality rate. Now, the type of e-liquid vaped, the majority were vaping THC products, 86%. 34% of these were combined THC and nicotine products, and only 11% of cases occurred in those vaping nicotine alone. 78% of individuals reported obtaining these e-liquids through non-formal parties, such as friends, family, or other peers, or non-certified dealers. So what is the presentation of these cases of EVALI? Well, patients presented with a wide array of acuity and severity, but most commonly their symptoms would come on about 2 to 3 days with few flu-like symptoms, the majority endorsing shortness of breath, cough, and chest pain, as well as some GI symptoms such as nausea and vomiting. However, some people also endorsed coughing up blood or hemoptysis, and about 43% of people endorsed diarrhea. So you can have both pulmonary and GI manifestations. The diagnosis is one of exclusion, meaning that we must rule out pulmonary infection first. Diagnostic criteria includes endorsing vaping or dabbing within the past 90 days prior to symptom onset, opacities or widening out areas on the chest X-ray or a CT scan, and exclusion of other infectious etiologies. At the very least, we need to rule out a viral infection with a viral respiratory panel, and we need to perform a rapid flu test. There should also be considerations for things like blood cultures, sputum cultures, or something called a BAL. A BAL is a tool we use in pulmonary. Now we take a small scope with a sedated patient and we pass it down into their airways. We instill some salt water and then we suction that salt water back out in order to get a sample of the fluid in the airways, sometimes looking for things like infection, other times looking for markers of potential illness. So we should also be testing people for opportunistic infections if they're more predisposed to these things. So that'd be like in immunocompromised patients. And of course, there has to be an absence of other plausible diagnoses in order to fit the diagnosis of E. valley. So this BAL, or again bronchoalveolar lavage, can show abundant lipid-laden macrophages, which are immune-fighting cells filled with fat material, and an elevated 8-isoprostaglandin F2 alpha level. This is a very specific marker that shows oxidative stress as a biomarker specific for these E. valley cases. What are some of the X-ray and CT findings? Like we said, as part of the diagnostic criteria, we have to have whiting out on the X-ray or CT. So about 83% will show these opacities on X-ray alone. And the X-ray I show here demonstrates some hyperinflated or big lung fields, as well as on the bottom side of each lung or near the lung base, we see whiting out. The CT scan here shows several different slices. In the first slice, you see a lot of whited out areas in the bottom of the lungs. However, this whiting out persists as we go up the lungs towards the base of the lungs. What is the underlying mechanism that we believe is causing these E. valley cases? Actually, the mechanism is unknown still. We don't know for sure, but we have suspicion that it has something to do with a compound called vitamin E acetate. In one study where they performed a bronchoalveolar lavage on 51 patients with E. valley, they showed that 48 out of the 51 tested positive for this vitamin E acetate. Vitamin E acetate has a similar viscosity or thickness in the fluid compared to that of THC oils. So if you're selling these marijuana or THC vapes, some of the dealers will cut that vape with vitamin E acetate in order to decrease the production costs. However, unfortunately, the vitamin E acetate has a very aliphatic hydrocarbon tail, and it can align itself with the hydrocarbons found in the phospholipids of surfactant. And this forms crystallization of that surfactant, and it loses its ability to maintain the cell surface area or the surface tension of the air sac. So what does all that mean? Well, that means that unfortunately our air sacs in our lungs start collapsing down due to interference from the vitamin E acetate. And it's hard to open those air sacs back up once they start collapsing down. Heating of the vitamin E acetate also produces something called ketenes, which are lung irritants as well. How do we manage these patients? Well, it's a little challenging. The first step to managing is deciding whether or not a patient needs to be hospitalized. This, of course, is based off of vital signs and physical exam of the patient. Then, if they do require hospitalization, you have to decide whether or not they need any kind of respiratory support. And this could be in the form of supplemental oxygen or even intubation and mechanical ventilation. Empiric antimicrobial coverage should be considered because, again, you have to rule out an infection prior to treating or assuming a diagnosis of E. valley. Lastly, for those with progressive disease cases, systemic glucocorticoids such as methylprednisone has been effective in helping to relieve symptoms. Now, in severe cases, patients might even require cardiopulmonary bypass with an ECMO device. So what's the prognosis for these patients? Well, in one case series of 53 patients, which is quite a bit, showed 87% of these cases required supplemental oxygen. About over a third of these patients required BiPAP support, which is a mask on the face to help to provide breaths for the patient, and 32% required intubation and mechanical ventilation, which is about a third. That is a high percentage of patients. Prior to discharge, a patient should be off of their supplemental oxygen for at least 1 to 2 days, and they should have a follow-up in their primary care physician's office about 2 days after discharge. They should also be seen by a pulmonologist 2 to 4 weeks after their discharge. Now, patients should strictly avoid further e-cigarette or vaping devices, with an emphasis on those devices containing THC or those produced or purchased through non-commercial markets. Again, it's going to be non-commercial markets that are going to be the ones who are cutting these THC products with that vitamin E acetate. And really, for patients who underwent this experience, that should go without saying that they should avoid vaping. So what is the provider's role in all this? Well, we should ask many screening questions. Has a patient ever vaped? And if so, have they vaped within the past 90 days? What types of vaping devices were used? What type of e-liquid products were used? Were the cartridges pods or cartridges or pods, and were they reused? If so, were they filled with homemade substances, unlicensed, or commercially purchased products? And then were the products concentrated prior to use? And when did the patient start vaping relative to the onset of symptoms? And how often was the patient vaping prior to symptom onset as well? Ask the patient or the family member to provide a sample of the e-liquid so that we can send it for testing to the local health department. And report any suspected cases to your health department. Patients should be counseled on cessation of vaping and tobacco product smoking afterwards as well. Really, any patient who smokes or vapes should be counseled on cessation. So, some vaping cessation medications. Unfortunately, right now, there are no FDA-approved medications for the cessation of vaping in the pediatric population. There are 3 commonly used medications on the adult side. One of these being bupropion, which is also known as Wellbutrin, varenicline or Chantix. This is actually available in some pediatric patients, 17 years or older, and then nicotine replacement therapy or NRT. These includes things like the transdermal patches, gum, lozenges, nasal spray, or even oral inhalers, which are new to the market. The American Academy of Pediatrics, or AAP, recommends use of NRT, nicotine replacement therapy, in adults with nicotine addiction, but this requires a prescription in patients who are under the age of 18. Now, they also recommend a combination of these NRT. So that includes both long-acting and short-acting NRT. The long-acting being the transdermal patches, and the short-acting being things like the gums, lozenges, nasal sprays, or oral inhalers. In a recent study out this year, varenicline was found to have, varenicline in combination with behavioral counseling was found to be twice as effective in achieving 30-day remission of vaping compared to placebo or sugar pill and counseling alone. Now, I want to conclude my part of the talk here with a paper that I really liked, and that's called The Paradox of Vaping. This hit on many different common questions when it came to vaping. The first, and maybe the most common question I get, is can vaping be used for smoking cessation in patients who currently smoke? Now, there are many different papers on this topic, and honestly, the evidence is very mixed, and many of the papers contradict each other, and other studies are shown to have major flaws. Some of the newer evidence points to, yes, maybe in those who have a history of cigarette smoking, or at least adults who have a history of cigarette smoking, vaping can indeed help them to quit cigarette smoking. Now, in one study, they showed that using vaping for helping to quit cigarette smoking showed about an 18% rate of quitting, as opposed to only a 10% rate of quitting in those using nicotine replacement therapy after 1 year. However, there is one big notable factor about this, and that's that the patients who used vaping to help them quit cigarette smoking, 80% of those patients were still vaping at the end of that 1 year time. As opposed to those who were using nicotine replacement therapy to help them quit, only 9% still required help at the end of that 1 year. Is vaping a risk for initiation of cigarette smoking? Yes, in pediatric patients, this has been a consistent finding in the literature. Patients are 4 to 5 times more likely to start using combustible tobacco smoking if they have a history of vaping. Those with a history of vaping who started smoking also did so more intensely and more frequently. And 22% of new youth cigarette smokers had a previous history of vaping. So, how about, is tobacco smoke or traditional smoking worse than cigarette smoking? Well, all signs point to yes, but only in certain ways. Vaping is still not benign. It can lead to increased atherosclerosis or heart attack risk at a 1.4 higher odds ratio. It can induce seizures for those who are more predisposed or who have epilepsy. There's always a risk of toddlers or young children around the household ingesting the e-liquid pods. And then finally, there's a potential risk even of the pods themselves or the devices themselves combusting and causing burn damages to the fingers or the oral area. And so the risk mount, and this is on top of the risk to the lungs that we already discussed earlier. So How do we go about regulating vaping? This was more of an opinion portion of this article. And their opinion was stricter regulation of online purchases, age limitations, which we're already doing a pretty good job with here in Alabama, bans on advertisements, specifically those targeted towards youth, and then also certain flavor bans such as the candy flavors or the fruit flavors or the mint flavors that are more directed towards youths, as we saw in the National Youth Tobacco Survey. Their number one recommendation, though, was to increase taxation on vaping products. Currently, it's actually cheaper to vape than it is to buy traditional cigarettes. Traditional cigarettes are highly taxed right now. And in fact, most vaping pods cost 3 times less than your average pack of cigarettes. And again, these vaping pods can have up to 4.5 higher times of nicotine content compared to a typical cigarette. So I'd like to thank you for listening to my portion of the talk here. I do have many vaping and e-cigarette related sensation articles, as well as other resources that I'm happy to share with you. Here's my address, kblyton@uabmc.edu. If you have any questions regarding vaping, or if you'd like me to share some of these resources with you, please feel free to email me at any time. I'll be passing over to my colleague, Robin Herr, right now, and she'll be talking about vaping cessation counseling. Thank you.
Wow, thank you, Dr. Blyton. You really gave us a compelling amount of information and data. And I think it all just shows us that we're dealing with a very vulnerable population. And I'm thinking, what next? As we've heard this information, we're thinking about our patients and our students. What can we do to use this information to help our public population and our pediatric population? So it's an honor to be with you today and to have a few minutes to talk with you about how to provide meaningful interventions with our youth in order to really offer effective support in helping them quit vaping. Think about your role with your patients, with your students. Think about the opportunities that you've had in the past, and I wonder if you feel comfortable talking with them about their smoking habits or their vaping habits. I wonder if you found some effective conversations. Do you feel nervous about future conversations, providing intervention, or maybe you're really excited about learning how better to connect with our youth? I hope that today, in these next few minutes, I can share with you some things, sort of some foundational understandings, as well as some very specific resources that will truly help you feel more confident and equipped in talking with your youth. You yourself, in your role, can help your patients and your students quit tobacco use. We know when it comes to adults that tobacco use is the leading cause of preventable death and disease in the United States. We have a pretty good idea of how to help adults quit smoking, but we want to use some of these ideas and some of these strategies now to help our youth offering up from their vaping use, tobacco use, nicotine addiction. We need to understand that tobacco use and dependence is a chronic, relapsing condition that, like other chronic diseases, may require repeated intervention and long-term support. Most people, including our youth who use tobacco, want to quit, and most try to quit multiple times before actually succeeding. So as an educator, or your role as a healthcare professional, you truly play a critical role in helping youth quit using tobacco. So let's take a look. It's important for us to understand a little bit about nicotine addiction. And I think we're going to see as we walk through some of this information that when we try to consider how to create a safe place, a safe space for our youth to talk with us about their questions regarding nicotine and maybe hopefully share with us their use or maybe their need for interventions or help, we have to think about where they're coming from. What is the environment that they're in at schools, within the community? What types of devices, and Dr. Blyton has really shared with us about the specific devices, but all of this together, this culture of vaping is important for us to understand so we can meet the individual needs of our youth. So I love how the American Lung Association guides us in understanding about nicotine addiction, and they describe this addiction as a three-link chain. If we understand how this three-link chain really encompasses a youth's total life, their habits, their environment, I think we can really get at the core issues that will help us understand how to guide them in quitting and also in prevention. So the first link that the American Lung Association describes is a mental link. This mental aspect deals with sort of the routine, the daily routine of a young person. And for someone who's vaping, this may mean waking up in the morning, vaping first thing, maybe trying to figure out throughout the day how they can get a hit in order to sustain their need for nicotine. It also includes just triggers. What throughout the day does a young person find causes them to want to vape more? And then understanding this type of routine helps us really focus in on how to avoid those triggers, how to guide our youth in thinking, what can they do so they're not put in a situation where they're going to want to vape? And then also, are there specific things that they can replace with the habit of vaping? For example, taking on a new hobby, maybe taking on a new sport, a new group at school, becoming more involved in things, and replacing the actual vaping with something that's much more connective with their community, and then also something that's going to be very healthy. So the second aspect of this very strong nicotine addiction chain is the social aspect. We know, as Dr. Blyton has mentioned in his data, that a lot of youth do begin vaping. They're initiated into vaping for very innocent reasons. They just want to fit in. They want to be accepted. And these are really natural reasons for wanting to be part of a community. But it's just when it's involving such a harmful, risky habit of vaping that we want to, in our conversations with our youth, we want to try to understand why they're choosing to vape. And if they're falling into this cultural, this social trap, we can understand why. Because their environment believes that vaping is harmless. Their environment believes that it's okay and it's just part of the trends, and don't really understand the health harms that Dr. Blyton told us about. So we can have understanding, and that can lead us to really ask questions and try to understand more fully the what vaping brings to them, how that makes them feel a part of their group, but then really replacing again the habit of vaping with activities that bring a community, but in a very healthy way. And then the third link of this chain would be the physical effect. We know, as Dr. Blyton shared with us, that vaping really brings such intense levels of nicotine to the brain. In fact, when someone takes a hit, it takes about 7 to 8 seconds before that nicotine level actually reaches the brain, which is very quick. And it's no wonder that our youth are becoming so addicted so quickly when we think that even some of the vapes that are most popularly being used today can be the equivalent of 45 packs of cigarettes. So I was recently at a school, and the resource officer showed me a vape that he had confiscated. And just to show you what our youth are dealing with, this particular vape was equivalent to 9,000 puffs. 9,000 puffs we know is equivalent to about 900 cigarettes. So this strawberry flavored vape was most likely being vaped by, I'm guessing, a 15, 16, maybe 17-year-old student, maybe a girl. And to consider that the brain, this child is vaping a vape that is equivalent to 900 cigarettes, or the amount of nicotine that's in 45 packs of cigarettes, is really alarming, and it should be a red flag for us to really consider how we can play a more effective role in helping our youth quit. So this is an example of just how much nicotine is there available for our young people, and this is having a long-lasting effect on their health. And when it comes to addiction, it's nearly impossible to, on their own, for a youth to quit vaping. So that's why we want to understand that there's a mental aspect, the social aspect, and the physical aspect. And when we address each of these with our youth, whether our students or they're our patients, we can see that we can be much more effective in helping them come up with solutions to their daily lives that will help them quit using vapes and return to healthy, happy lifestyles. So Dr. Blyton mentioned using nicotine replacement therapy, and I've added this in at the bottom, the nicotine replacement therapy, or NRT, plus counseling, plus support equals a successful quit and staying quit. This is definitely evidence-based guidance for working with adults who are smoking, and we are able to see that we can use some of these guidelines in dealing with youth. When it comes to nicotine replacement therapy, as Dr. Blyton said, a pediatrician would need to be the one to prescribe that to their pediatric patients. In the clinical setting, we can better understand just how much vaping is a part of a youth's life or our patients' lives. And this is a set of questions that I really like using. It's from the FDA Center for Tobacco Products. So answering yes to any of these questions means it's time to get help quitting. The need to vape as soon as you wake up or during class, feeling anxious or irritable when you want to vape, having trouble concentrating or sleeping, keeping vaping even though you know it's bad for you, finding yourself reaching for your vape without thinking about it, and then just having these daily thoughts or these interruptions about vaping throughout the day. All of these are signs that your youth, your patient or your student really needs to address this and get some help. This can be used in a set of physical questions, or even better, understanding this sort of flow and creating a conversation in your discussion with your patients in a way that's very natural. Basic guidance, basic evidence-based guidance really does for us advise quitting and then offer treatment. So from a clinical setting, we should be asking every patient about their tobacco use at every visit, and Dr. Blyton also touched on this. We should offer patients who use tobacco help quitting at every visit. We should advise patients who use tobacco that quitting is one of the most important things they can do for their health. And then offer evidence-based cessation treatment, including counseling and medication. And then we said that the pediatrician would be the guide as far as prescribing the nicotine replacement therapy. Offering referrals to additional cessation resources, such as including 1-800-QUIT-NOW. We know that this program includes counseling, which again is evidence-based, and then medication in the form of nicotine replacement therapy patches. But this service is for those who are 18 and older. However, the 1-800-QUIT-NOW line does provide this resource to any child, any any person who is under 18 with the permission of the parent, but it does exclude the nicotine replacement therapy. So for your patients, for your students, this can also be a resource for them, the 1-800-ALABAMA Quit Now line. And then following up with your patients is very important, just to see how they're doing and just to continue offering support through the quitting process. All right, basic tips, and these tips are really good for dealing with this vulnerable population from a public health perspective. So these are some tips that you can use with your family. They're tips that you can use, again, with patients and also with your students at school. It would be talking to your doctor at an annual visit with the pediatrician. When the parent is not there, this is a really great time to address tobacco use. And then I'll also include there talking with a counselor. As mentioned in the other slide, counselors can really help a young person understand why they're vaping and talk about the triggers and the other suggestions of how to, within their daily lives, how they can address some of the problems that may be leading to their vaping use, as well as just general wellness and mental health guidance. And then picking a quit date. It's really important when you have a youth that's ready to quit to help them pick a quit date within the next week or the latest in the next 2 weeks. Part of this will include talking about the triggers, talking about the times throughout the day that they feel they're going to be challenged, they're going to want to continue vaping, and then guiding them to understand how they can maneuver around those triggers and find, again, healthy ways to replace vaping. So the next, replacing with a healthy choice. A lot of youth really benefit from maybe snacking on healthy, crunchy carrots or other types of vegetables, maybe having a straw handy that they can keep in their pocket to chew on, to keep them from desiring or craving that oral cessation that comes from bringing the vape to their mouth. Believe it or not, a lot of young people have a struggle when they quit vaping with the hand-to-mouth motion. They're so used to bringing the vape up to their mouth that that's another thing that we can address, helping them keep a little fidget toy in their pocket, maybe, again, the straw or a sucker, something that will help them replace the desire to want to vape. And then, like we mentioned, the nicotine replacement therapy. And key, I think, is getting to support. Our youth need us as adults, as their care team members, as their, school, as their teachers, their parents. Really, as a community, we can provide this supportive guidance that they truly need to get through a very difficult time. Then I love what the American Academy of Pediatrics has given to us in the way of this wonderful resource called ACT. So it's really geared toward youth tobacco cessation. And we can ask 3 questions when we are providing this meaningful intervention with our patients in a clinical setting. And what I like about this flow chart, this conversation flow, is that it can be short. It can be 2 to 3 minutes, or we can make it longer. I also like to adapt this and use it within a school setting, so a school nurse could also use ACT to help understand if their patient or if their student is using tobacco. So the first question is ask, and that is just simply ask, are you currently using any type of tobacco? And then if the answer is no, it's really important for us to use this opportunity to say just how important it is that they've made that choice not to vape or to be tobacco free. And then as we ask more questions, we might want to talk about the specific products that are common today. And again, that's why it's so important that we understand what is being vaped in our particular environment, so they know that we are up to date and they know that we are aware, and they can connect with us more easily in that sense. And then we also can talk about confidentiality. So it's really important that we respect and we honor the confidentiality of our patients, and then for sure our students in our local schools. If our patient or our student does say yes, they are using tobacco, then we'll move on to the second step, which is counsel. We want to counsel all patients who use tobacco about quitting, and then this is regardless of the amount. We know there's no safe use of nicotine. So some questions that we might follow up with, when they tell us that they are using. Our counseling can include just how harmful nicotine is to youth and children's brain development. We can also talk about how quitting really protects their health, how it saves them money. And then we can remind them that quitting is hard, and we are there for them. We are part of this social and medical network that is there to help support them through a very difficult quit. And then at that point, we can ask, are you ready to quit? And if the answer is no, we want to just make a little note of that and just remind them that we understand it's difficult, and then we will be there for them in the future. And then, of course, bring that back up in the next clinical visit. If they are willing to quit, this is the moment that we really cherish, because we know what a huge difference this can make in their lives. So this is when we reach the third step of treatment. Treatment doesn't have to mean that we actually provide treatment for them, but it can also mean a referral. So treatment means linking our youth to the appropriate behavioral supports, considering here the possible prescribing of the nicotine replacement therapy if the pediatrician or doctor feels that that's effective and appropriate in this particular person's situation. And then we're going to talk a few minutes about some resources here, but there are programs that can really help our youth, and we can ask our youth, what do you think would be most helpful for you? Would it be a text-to-quit program? Would it be something online? Would it be something in person where you can talk with a counselor about quitting? And then encourage them that the program will help them quit and stay quit. And then lastly is, again, this important step of following up with them when they come back to their next visit. So let's take a look. If you are in this opportunity of speaking with your patient, there are some very specific resources that you can use at this point. And the ones that I would like to share with you, again, I mentioned the 1-800-QUIT-NOW line. And then I really like the teen.smokefree.gov. So this is great for parents. This is great for care team members as well as school administrators to go to this website and just become familiar with the topics. What does it mean when someone decides to quit vaping? What kind of withdrawal symptoms are they going to be experiencing? So this is a great resource for all of us, just a general public health resource, but it's also really great for our teens. So they can be referred also to this Text to Quit program. It's made available to us by the Truth Initiative, and it's called This Is Quitting. It's for youth ages 13 to 24. All they have to do is text Ditch Vape to 88709, and they'll receive text-based coaching. This will be in the form of motivational text. It will help them deal with issues like cravings, maybe peer pressure, what to do when they're feeling sad. It definitely focuses on the mental wellness aspect. And we're finding that nationwide, this Text to Quit program has been very successful in helping our youth quit. And then when it comes to us providing these resources, we have to remember that our mindset is especially important. We want to show our youth that we respect them as the young adults that they are. Certainly trying to condemn them or preach to them in a certain way turns them off. So we want to create an environment where they feel they can trust us and they know that we truly care about them and about their health. So we, in our roles, can be educators. We can understand the culture that they're living in, and we can provide this support, and we can definitely provide encouragement that we believe can help them successfully quit and then stay quit. This is the last resource that I want to touch on, and I found in my work that a very effective and efficient perspective for our youth comes from their own peers. I would love to recommend for all of us that we use our peer helpers, these students within our school systems that are already leaders. If we can bring this message to them and have them sort through it and decide the best way to share this with peers, I think that this is really a key moving forward for us. And I think we can see effective change with this peer-to-peer model of providing resources, guidance, care from the peer perspective. So Children's of Alabama, along with the help of Spain Park High School and their amazing peer helpers, have put together this 3-minute video. It's a peer-to-peer that covers all the aspects that we've talked about today, and it's called Vaping, Why Risk It? And please feel free to share this throughout your communities, and I hope it can be a resource that you find beneficial, as I have. So in closing, I want to bring us back to this idea that we are a supportive community, and for this vulnerable population, we really each have a wonderful opportunity to interact, to find ways, creative ways to reach our young adults. And this is a picture of just the community that we are involved in at UAB. And I want you to try to place yourself in there. This is a mix of the peer helpers that I mentioned to you, along with some of our other school partners. There's the school board. Local school boards are represented here, along with our respiratory therapists, our nutritionists, our pulmonologists, our high school principals, our assistant principals, our care team members. We are so appreciative just of your role, and I just want to thank you for your care, for your compassion, and for your interest in wanting to help our youth. And I hope that you found in our discussion today some new ways to approach this, and I just wish you all the best in providing these meaningful, very meaningful interventions on behalf of our vulnerable youth. So thank you very much for today. I've enjoyed it.
Absolutely.
We have a couple of questions that come in. The first one has to do with, it says students reported that when they vaped, it was for self-medication, for anxiety, depression, other mental health issues. How are these mental health issues being addressed or treated once their vaping is identified?
Yeah, so I'll take that one to begin with, at least, and please add anything you'd like to. So I think that you uncover two things at once there, right? You uncover vaping, and that needs to be dealt with, as we already discussed, but you're also uncovering that these patients do have a degree of anxiety or depression that they feel like that they don't have anywhere else to go with. So I think as a provider, it's up to you, in order to know your local resources, to know what kind of counseling is available, what medications might be good for that particular patient, and of course, gauging their own interest. You know, I'm not just a pulmonologist, I'm a pediatrician as well. And as part of my training, we see a lot of depression and anxiety, and in that row, I've familiarized myself quite a bit in the Birmingham area with different counseling, psychological, and medicinal resources to help those patients.
Do you sometimes put in the cart before the horse, or the horse before the cart, if you've got a patient that you know has got some anxiety or depression issues? Are you hitting them with don't vape, maybe before they even start?
Yeah, I think that is a great point too. Know your vulnerable populations, like we pointed out, and that's what I think the National Youth Tobacco Survey, by trying to register what patients are more likely to vape, was targeting those patient populations that fit that mold who are not yet vaping, and really hammering the point, if you have a couple of minutes left in your appointment time, to tell them about the dangers of vaping and why to avoid it. And at the same time, I'd like to point out that treating those symptoms of anxiety and depression in a more proper manner is going to help them to stop vaping also.
The last question I have has to do with the vaping industry. Do y'all see any pressure? Are y'all receiving any pressure from the vaping industry to not talk about this or to be quiet?
You know, I've also often wondered that myself. I have not, personally. I think Robin is a bigger name within our industry in the local area, though, and so I don't know if you've had that experience.
I have not personally felt that, but I will say we have to ask this question, because even a fifth grader can say, if these are so harmful, why are they being sold? And our kids, our youth, our children are really savvy, and they can understand once we bring this to their attention and we say, why do you think the vapes that are loaded with the most amount of nicotine are the cheapest? Why does the local convenience store so readily sell vapes to underage children? And I think it becomes clear. It's a message that once it's put out there, our youth can understand that there is a marketing campaign, there's an industry that's preying on them. And if they can just refuse it, if they can just be reminded that they are so much more than getting into vaping, and they can really see their futures, I think those conversations are key for us to have with our children, with our patients, with our kids at school, our students. And I think those conversations need to start early. But it does feel overwhelming. I'm going to be honest, it feels overwhelming when we know that public health issues are going the wayside and profits seem to be leading this whole industry.
Thank you both for today. This concludes our program for today. I want to thank our presenters for being here, and thank you for watching. Please remember that you can refer back to the training and resources anytime on demand. Have a great day.